intravascular stenting in combination with the coiling, okay? So, endovascular, intervention is probably what we do 95% of the time. There are very few that we clip anymore, thank goodness. Very few. The ones that need clipping that really, or they need more surgical intervention, or maybe in combination, are ones with a hematoma on top of, where you need to evacuate the hematoma, and you're not gonna evacuate a hematoma on top of an aneurysm rupture. It'll rebleed in that instance. So you can get pretty complicated situations, okay? Again, follow-up imaging is, you've gotta do that to make sure that you close, that you clot off that aneurysm, okay? And again, catheter angiography is the, treatment of choice there. Okay. A lot of different coiling systems, but it really looks like, it looks kind of like a little metal right there, but it looks like spaghetti when you see them do it. And then this bottom right picture, you have that stent assisted treatment for that. Okay, time to surgery and rebleeding rates. This is the International Cooperative Study on the timing of aneurysm surgery, 0 to 3 days, and we try to get it within 24 hours of that patient. So early on, I've been around long enough to know that early on, before we had all this coiling and endovascular stuff, one of the professors at our med center would send patients home and clip them electively. And if they showed back up, if they didn't die, and so of course he had great rates from his coiling or his clipping, because the patients that, died in between times were not in his data. His data had, yes, this was like probably 40 years ago. They were sent home.
Is this study,
It's an older study.
yeah, I was gonna say, is this based off of the clippings, when clippings are more common compared to endovascular treatment?
Yeah, because we can do a lot. We can do faster endo treatment now that we can surgical. The IR suite's pretty available. And again, I don't think that people really understood the urgency of treating this. They were like, oh, well, there's not much we can do. And so that's why these early studies are really important, because it informs us what we do now.
I feel like it's still hard, there's a bunch of providers that will
wait,
and I don't know if it's maybe the older ones or the younger, I don't know which group it is, but some will jump at doing, taking care of the aneurysm, and some will just be like, yeah, we'll just watch it.
See that? Yeah.
I don't know, and I wonder what the, are they getting control of risk factors? The other thing too that I always wonder about is the unconscious bias that's associated with the 30-day mortality on their procedure.
Really?
You know what I mean? I don't know.
Yeah,
I don't know,
maybe.
but it is one of the metrics. It is one of the quality metrics, right? Is 30-day mortality after procedure or after surgery. I always wonder about that.
That'd be sad.
It would be sad, but I do always wonder if that's kind of if that's an unconscious sort of thing when they're looking at mortality. Is this something I can wait on, or is this something that's going to be? I just always wonder.
Yeah.
I wonder about that with my people sometimes when they don't do stuff immediate. I'm like, why are we not doing that?
Right.
I think we do see that a bit in ICU, especially with the really severe bleeds that come in, where there is a conversation going
yeah, but they don't want to do anything. They don't want, because they're going to die.
Exactly. Well, and even with the family saying we want to do full treatment, or we will see the surgeon go I'm not going to attempt to evacuate anything because they because of futility.
Yeah.
But
yeah. So I don't know. I just always wonder about that. And I also wonder if there is there is, I think there is an argument to be made for cooling people down. Before you put them under, because surgery is stressful, and putting them under anesthesia and all of those kinds of things. So I also wonder if it's just a time period of cooling off. So I don't know. But I do always wonder about the unconscious bias, because you can't, it is a metric that they have, it's a metric they have to care about,
Right.
but I don't know. Yep, okay, cooling versus clipping, the size of an aneurysm the geometry of the aneurysm matters, the neck diameter we look at, the location in the brain matters too. And will cooling be better tolerated than surgery? For most patients, yes, it will. And again, I mentioned before, is there a large parenchymal hematoma that should be evacuated? And that was the case with one of ours. We were like, we can do a combo procedure, but the reality is this needs a clipping. It was an MCA aneurysm. And you can get to that pretty easily. It was an MCA aneurysm, but you needed to evacuate the hematoma. And once you evacuate the hematoma, the aneurysm will rebleed. Because that hematoma is tamponading. And so that was a patient that was quite scary. Okay, and again, just the timing of all of that. Oh, look at that. There's cooling right there. Done. Looks pretty good. You gotta monitor those patients, because you can also get an incomplete situation there. Okay. So again, in terms of endovascular versus one of the earlier trials, ISAT said, you know what, they do better if we coil them versus clip them, but it's generalizable to awake young anterior circulation aneurysms only. So that came out of the ISAT trial. Seizures can occur up to 20% of patients, usually within the first 24 hours. And again, MCA, ACOM locations are more associated with that. But again, the guidelines don't recommend routine prophylaxis. And again, utilizing EEG when you need to. Okay. Subarachnoid hemorrhages, these are the sickest patients in our unit, I think, because they can turn on a dime. One moment they're fine, and the next moment they are not. And usually when we talk about cardiac dysfunction, it's really important to teach our nursing staff to watch the EKG. Sometimes they get so focused on the neuro stuff, they don't realize that these EKG changes are actually precipitated by the subarachnoid hemorrhage. They can actually go into stunned myocardium and severe impairment of the myocardial contractility. Takotsubo, do y'all know what Takotsubo is?
Broken heart.
Yeah, it is, but you know what it looks like on imaging and that kind of stuff?
It's like
It is,
pod.
the apex sort of, do you know what Takotsubo actually means?
the octopus pod.
That's it, yeah. You're on fire. Is that in there? Is that in that book?
No.
Okay.
No, that
No,
is
I
not
thought
in
it
the,
just
that
checked.
is not
I know
in the
he
book.
cheats, that's
I
fine.
was like, you cheated yesterday. Okay.
It's not, it's right in front of you.
Yeah, so, and, for these patients, the EKG matters. Echo is really important to get a baseline echo. And if you're having trouble with somebody's blood pressure, or you're having trouble with weird heart rates, repeating the echo and looking at their ejection fraction. And very important. The most severe patient I had went into just massive heart failure acutely, and we actually put her on balloon pump. Listen, if I could, I stuck a drain in everything we could stick a drain in. She had BDD, she had this, she had that, and she was on balloon pump for about 3 or 4 days. And so she ended up, she ended up probably with a modified ranking of 3. So I mean, she lived through it. But I had to go to them and say, we should put her on balloon pump because we had never done it before. And you don't put them on it prophylactically, but when you have a person who is in this, you should treat them like a heart failure patient and go ahead and do it. We did 1-to-1, so we did have to anticoagulate her. And so I had to I was standing around in the ICU with the critical care intensivist, the cardiologist, the heart failure surgeon, my neurosurgeon, the neurologist, and I was showing them papers. I said, we need to put her on balloon pump. So anyway, and so she ended up, in this particular case, her ejection fraction ended up recovering from all of that. A lot of inflammatory stimulation here, okay? Okay, so again, SIRS increases the risk for death, obviously. Here's the diagnostic criteria for SIRS. It's independently associated in this context with surgical clipping, poor clinical grade, in other words, a Hunt Hess that has a poor grade on it, admission, blood pressure, and aneurysm size. Okay, a lot of inflammation going on here. Vasospasm and delayed cerebral ischemia is really one of the more feared complications of subarachnoid hemorrhage. Okay, again, you get that diminished perfusion in the distal territory. It can onset 3 to 5 days post bleed, maximal risk at 5 to 14 days, and you get some gradual resolution after a couple of weeks. But with that, with all this vasospasm, you can also have delayed ischemic stroke in these patients, and so that's what accounts for the majority, or at least half the deaths associated with subarachnoid hemorrhage. Okay? And TCD screening is really important, and treatment of their vasospasm, whether it's going back to the lab or raising their blood pressure or any of those treatments. Okay. Again, contributors to perfusion, myocardial function. If your heart is not functioning well, you're not going to perfuse. And that was my big concern with this patient that we put on balloon pump. I thought, she's got an EF of like 15 right now. She came in with an EF of 60. So we're not doing anything right now for her. And anyway, so myocardial function, that's the reason for the echo. Really important to get that echo. And again, making sure that that our volumes are good. Watching that mean arterial pressure, making sure it's perfusing pressure. Watching our ICP with those EDDs, and making sure that we're oxygenating these patients. All of these things are contributors to perfusion, obviously. Okay, let me get there. Oh, hang on a minute. Let me do this. Okay, vasospasm. Nimodipine does not reduce vasospasm. Does not. We think it works by exerting a neuroprotective effect that sort of raises the threshold for ischemia and preventing accumulation of toxic substances associated with the blood. Okay, so when we did the early trials on clazosentan and nimodipine, clazosentan reduced radiographic spasm, but it didn't result in any different neuro outcomes. Nimodipine did not reduce radiographic vasospasm, but those patients did better. So again, it's not about the vasospasm, it's about that neuroprotective effect. And making sure that our nursing staff knows, even when they're NPO, they have to have it. If they're NPO for some reason, give it to them. Do y'all have the oral form?
Yeah, we
Use the oral
usually
form
drop-
for the
usually drop KOs on them and then just
Mhm.
give the
Yeah.
solution.
I wish we had the solution. We had, so what we've done instead, because our pharmacy won't buy the solution, we've had pharmacy sort of, because, before we'd have to melt them or we'd have to put it in a syringe, the little capsules. And I'm sure that, yeah,
We had to do that.
yeah, we did that too. And I'm sure they didn't get everything that they were supposed to have. And so pharmacy started doing that for us, so they'll just send it back to us.
What's the nice thing about being like a Pete's hospital is we have the ability to turn a lot of stuff into oral solutions.
Yeah,
so it's-
exactly. So that makes it really nice.
Yeah.
Yeah, very nice. Angioplasty, again, going back to the lab, really does help, and sometimes you have to do that every single day. Okay. Some of the earlier trials didn't show any difference in outcomes, but we still do it because sometimes that's all you can do. So when you've done everything you can do, trying to stay, especially these young patients, because they're so young when they have these. these things, you wanna do everything. The vasodilators, nicardipine, verapamil, in terms of local, injection, reported to, reduce vasospasm. And the interventional guys, they use it. When we talk about hydrocephalus, because, again, you produce about a half a liter of CSF a day, and, but you resorb 2/3 of it. But when you have all the blood blocking the villi, it clogs it up, and you just don't get, the absorption that you should have. So probably up to a quarter of them, will need shunts because of that, and it doesn't matter what treatment you do. Okay? Yeah, that patient's getting a shunt. I don't care how they do, they're getting a shunt. See that big third ventricle? That's a patient that, doesn't appear to have an EVD yet, needs one. Hyponatremia is a real problem, with these patients too, and it's associated with poor clinical grade, ACOM aneurysms or hydrocephalus. And you gotta differentiate between DI and cerebral salt wasting. So you need to differentiate between the two because the treatments aren't the same, okay? We really wanna minimize free water administration in these patients, and use only isotonic IV fluids. We do use some mildly hypertonic, like 3% saline. And there is, at least one small series, with the use of Florinef to help with that cerebral salt wasting. But the salt just goes out in the urine. And so, anyway, so differentiating between DI, cerebral salt wasting, is really important. Oh, I didn't realize that these were. Last one, AVM. We might make it, y'all. AVMs, again, we've done a lot with angiography over the years, in the 50s and the 60s. But looking at these, arteriovenous, malformations, these are high flow lesions, these are not low flow. And they're made up of arteries and veins that have been arterialized. The venous structure doesn't have the muscle layer that the arterial structure does in the vasculature. And so veins, once they become basically distended, they can't come back to their regular shape because they don't have that layer that the arteries do to be able to pulsate. Typically, congenital lesions arise in early fetal life, and they are developmentally immature vessels, and developmentally immature vessels sometimes can result in bleeds, and they can be big. This is a pretty big one on cross-section and autopsy. But these AVMs can harbor aneurysms on the feeding arteries. The cortical AVMs, the ones that are on the surface, most commonly involve the MCA territory, and the size varies. The larger the AVM, the larger the cardiac output, okay, demand. And they will steal it from normal brain tissue, which puts that normal brain tissue at risk because they're just sucking up the blood through these arteries and veins. Okay. Oh, hang on a minute. Okay. So the feeding arteries, they like that vasomotor control. So the blood flow into them is passive, it's not really active. And then you have those arterialized veins, okay? That nidus is the arterial and venous connection point. And so this is the reason why neurosurgeons will probably, if they have a cerebellar hemorrhage, they want to know the anatomy of the vessels in that hemorrhage. Because if you get into a nidus, willy-nilly, and you chase that, I had a young neurosurgeon who was gonna save the day and a young patient with a cerebellar hemorrhage and really didn't look closely at the anatomy. That would have been a case where maybe you would have done interventional and had them map that out a little bit and let that patient cool down a minute before you go straight to surgery. That would be an indication to let that patient cool down a minute and you get a plan together. But he chased this nidus, he chased it, and that patient ultimately did not survive, but it was just one of those things where you wanted to do something, it might have been better to wait. and assess the situation a little bit better. The still phenomenon is AVMs have some unique hemodynamics, and so they suck up the blood from normal perfusion pathways, and over time you get all these tissue changes, and so you can have focal deficits, you can have seizures from all of that, okay, from all of that still phenomenon. So and they can be really, really, really big. But the presentation, typically they're more symptomatic. They can be asymptomatic for decades, but typically during the second to fourth decades of life, so that's teens to 30s, okay? They present with headache, hemorrhage, deficit. They may present with seizures and even mass effect from them, okay? You can get some small deep ones that present with hemorrhage. But you can also, those cortical AVMs, anything in the cortex, you always think is a possible seizure waiting to happen, okay? And again, on the cortex, remember when we talked about yesterday, the cortex being especially in our motor strip area, get some focal deficits and get some mass effect from them. Do you need a new pen?
I was gonna say here.
I want you to have a new pen because it's surprising to me to have you sit here and
Cause I still did.
I want you to have a pen.
So I'm not sitting here just shaking.
I know, I'm like, please somebody have a pen.
Jackie, want you nice on that?
No, it's Alicia's first. But no, copy. Thank you.
Okay, all right, so again, anything cortical, think seizure risk, okay? Hemorrhage, obviously the most common clinical presentation, and again, teens to up to the 30s. Early rebleeding is uncommon, but the risk does increase each year after the initial bleed. Okay, here's the factors. These are what we think about when we talk about, because I've seen them really big in our clinic, and you know what? Sometimes you can't do anything with them. Probably the most famous treatment place is out in Barrow Institute, where Spetzler and his group works. They've done more with AVMs probably than anybody in the world, really. But the factors associated with how you treat them is the size, the location. Is it going to be more risky to do a surgery on them or treat them? What is the distribution, the number of feeding arteries? Do you know anything about the venous drainage pattern? The volume of the flow, high flow, obviously, the amount of steel, and large AVMs may require more than one kind of intervention. So you may have staged interventions for these patients. Okay. We will have our IR physicians embolize the vessels, so they can go in and do an angiogram and embolize that over time. You can certainly do it more than once over time and reduce the shunting. Okay. Typically, you don't do endovascular treatment as a sole form. You do it as a bridge that makes this surgery more likely to be successful. You certainly can regrow these areas as well, okay? Surgery provides the definitive treatment, but again, it's nice if you don't have to go deep in the brain. But again, this is an area where we do stereotactic radiosurgery. So stereotactic radiosurgery is like focused radiation. It's done by the radiation oncologist. And they can do focused radiation on that area just like they would treat a brain tumor. They can actually go in there and do very focal, finely tuned radiation for those. Okay.
Which is different than what we were talking about earlier.
Which is different than what we were talking about before.
Cause we
Yes.
use that here, but I don't think we do
Yeah.
the other here.
Yeah. Okay. All right. This is it. Don't worry about that picture. That's in the weeds. That's in the weeds. That's just glue, is what it's showing you is in the angio suite. They can put some like glue or something like that to embolize the vessels.
you know, similar to what they did with that